Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I'm your host for tonight's program on strokes and other neurologic problems. We're ready to take your questions about headaches, migraines, dementia, multiple sclerosis, Alzheimer's disease, and other neurologic conditions you might be concerned about. Remember, the success of this program depends on your questions. Please call in locally at 218-788-2844 or toll free at 1-877-307-8762. Keep those questions coming and we'll do our best to answer them all tonight. I'm pleased to welcome our panelists, Dr. Nick Itzin, an emergency room physician with Essentia Health St. Mary's Medical Center, Dr. Emily Onello, a family physician with Lake Superior Community Health Center and a faculty member at the Department of Family Medicine and Community Health at the Medical School Duluth, and Dr. Ruth Thomson, a neurologist with Essentia Health-Duluth Clinic. Our medical students answering the phones tonight are Ben Doomer from Cambridge, Minnesota, Susan Hoym from Grand Rapids, Minnesota, and Danielle Lavasser from Omega, Minnesota. And now on to tonight's program on stroke and other neurologic problems. We had a little discussion before the program tonight, and I think I'd like to start out with stroke, and we're really fortunate to have a panel with Dr. Onello, who's a family physician practicing in the community, Dr. Itzin in the emergency room, and Dr. Thomson handling the specialty of neurology here in the Northland. And I think it might be nice for us just to walk through stroke and talk about it a little bit, especially with the emphasis that we have in this state regarding acute and early awareness of stroke and getting the care it needs. We're kind of where heart was, I'm old, 35 years ago. So Dr. Onello, do you want to talk a little bit about stroke and what might cause it, and that type of thing, and start us out?
Certainly, Ray. Thank you. I think it's important to revisit what a stroke is. And many of us think of it as something we worry about in our older years. But a stroke can happen to any gender at any age. As we were discussing, you can see strokes even in young babies and infants. What a stroke, I would define it in my mind as a loss of oxygen to part of the brain. And so the tricky part of that is that the symptoms that a person might experience will vary depending on that part of the brain that is deprived of oxygen. So that's where it's a little hard for people to wrap their head around stroke, so to speak, because it might be slurred speech, it might be loss of motor function and strength, it could be loss of memory and thinking processes. So to expect a stroke to look the same in everyone is a mistake. It can be a very varied presentation, and that can make it tricky to diagnose. For patients to recognize as well.
Dr. Itzin, you're an emergency room physician, and it's been my feeling that with stroke, people need to move right away and get toward a major center. Do you want to elaborate on that a little bit, and then what you do?
Absolutely. I think the thing that people misunderstand about stroke is kind of rooted in the historical treatment of stroke. Prior to the past couple of decades, physicians and medicine in general haven't been able to do a great deal as far as the immediate treatment of stroke. It was, for the most part, looked upon as an event in life about which not a lot could be done. But what I like to encourage people to do is to compare strokes to heart attacks, because essentially they're quite the same thing. It's a blood vessel problem which results in the ultimate failure of an organ. For heart attacks, that involves the heart. For strokes, that involves the brain. People have chest pain and they think, well, I have to get to a hospital. And what I'd like to see now and in the future is when people have something which they might attribute to a brain problem along those same lines, that they react the same way, and that they think, well, I have to be into the hospital. Because there are things we do now as far as treatment. And furthermore, in the emergency department, there's a lot of things that I like to look for, which either may be something that is like stroke but not, or might be something that is what we call a downstream bad effect of strokes in general. So being able to kind of prepare a patient not only for immediate treatment options, but also for potential bad outcomes is very important.
Dr. Thomson, and you're kind of at the end of the stream on this. Do you want to add your comments in as to where neurologists fit into this and add into anything here that you think we should discuss too?
Right. So I guess I look at stroke as a very wide problem. You know, it starts with preventing strokes, I guess, is probably the biggest thing that we can do, is make sure that our patients and our family members and ourselves, you know, have a healthy diet and get enough exercise, and, you know, control their cholesterol levels, and make sure that their blood pressure isn't too high. You know, all these things that help our hearts also help our brains. So that, I think, is a really important component to it, prevention. And then also, you know, community awareness, as Nick was saying, you know, getting there on time is critical. We have a very short time window that we're able to deliver these very important and brain-saving, you know, treatments, including the clot-busting medications, but also there's intra-arterial treatments and other kinds of treatments that we can provide patients with if they get there in time. And then, you know, it follows through with the hospitalization and follow-up care. You know, it's very important that patients that have had strokes get access to rehab centers that are focused on providing stroke care, you know, post-stroke care. It's a very specialized area, and there's lots we can do to help people rehab. And then their follow-up care, you know, with their family physicians, and, you know, making sure that everyone is on track with, you know, optimizing their stroke risk factors, and making sure that, you know, we know what caused the stroke, and are able to attend to all these problems, and make sure that they're addressed.
So let's cycle right back around to those stroke risk factors, because we have some questions. There are questions regarding the risk factors for TIA, questions regarding the use of potato chips, Doritos, salt type things, hypertension, other factors. Emily, do you want to talk about stroke prevention and preventive care in the clinic, in the front lines?
Certainly. I appreciate your summary, because I think a lot of the major points were mentioned. I would just throw in there, of course, tobacco use, smoking, another habit that's, what would the word be?
Dangerous.
Yes, thank you, dangerous.
Preventable risk.
Preventable risk, right. I think, you know, many of these things do dovetail in. The salt, you mentioned potato chips and Doritos and things which incorporate salt, and we're still discovering the role that sodium component of salt has on blood vessels. I don't think we even fully understand it, but we know there's a link between salt and elevated blood pressure, and elevated blood pressure is most definitely a risk for stroke, and even the less common hemorrhagic or bleeding stroke. So I think that, as you said it best, what you can sort of piggyback on top of what our heart doctors tell us, that is heart healthy, the 5 fruits and vegetables a day, 30 minutes of at least a good walk a day. The more exercise you can do and physical activity, the better for your cardiovascular system. And you know, issues of controlling those risk factors, cholesterol, if you're a diabetic, having good control of your blood sugars. And also notifying family members, because I think that many of these conditions, risk factor conditions, and even strokes themselves, I believe if you have a family member who's had a stroke, that may well increase your own risk of stroke. So communicating as a family is helpful in terms of passing along that knowledge to reduce the risk.
And what I might add to that, actually, one thing that gets often forgotten is that if you have had a stroke or a heart attack, you're at much higher risk for another one for the rest of your life. And so I encounter people who have had a heart attack or have had heart disease or vascular disease on some level, and having been treated and having seen a time where they've been past that event or that particular diagnosis, don't consider it to be an active problem anymore. And I would encourage people to keep a close eye on their own medical histories, as it is something that gets overlooked, unfortunately, all too often.
And something I would add to that actually is the issue of TIA. I hear a lot of people say, oh, it was just a TIA. Well, unfortunately, a TIA is just a missed stroke. And actually, we can have strokes that we don't even recognize because it's sort of like Russian roulette. If the stroke ends up in a certain part of the brain, you might not even know that you've had the event. So a TIA and a stroke are really equal, in significance. And
which means if you have a TIA, you should go to the emergency department.
Exactly.
If you have what somebody calls a mini stroke, if you have what you think is a mini stroke, you should go to the emergency department. In this particular circumstance, it's not possible to overreact or overuse our resources. This is why we are
Absolutely.
there.
So Nick, when they come to your emergency room, because there's about a couple, 3 questions on this. What happens? How do you determine if it's a hemorrhagic stroke or a clot and all the rest? What does your team do? Is there a special team at your place? And how does that work?
Sure. Well, you might have to remind me as we go through the questions, but I'll start with what happens.
Okay.
So if you show up in my emergency department or just about any emergency department in the area, what is going to happen is that you're going to set off a level of suspicion just by the type of problem that you report. So if you're reporting a difficulty speaking or facial weakness, or if you're reporting for a family member who has the same, in our facility, that's going to set off what we call a stroke code. And many facilities have established something along that parallel. And essentially what that does is collects and arranges the appropriate people to make a very rapid assessment. Because as we've alluded, if a diagnosis of a stroke, particularly a ischemic stroke is made, there's treatment options which are available, but only on a very time-dependent basis. So if a stroke code is queued, what you'll have is a dedicated nurse and a dedicated physician in the room immediately to perform a very thorough, not only neurologic assessment, but interview and establishment of all the facts. Because as mentioned before, there are certain things which might look like strokes, but are actually manifestations of some other emergency problem. So we've got to sort that out. How do we tell if it's a ischemic versus hemorrhagic? So this means a bleeding stroke as opposed to a stroke consistent of a lack of blood flow. Well, we do that partially by interview and history, but mostly by imaging. So a CT scan or computed tomography scan is essentially works like a series of x-rays, giving us a two-dimensional organic picture. And that allows us to make a differentiation, bleeding against no bleeding. And what actually people find surprising is that ischemic stroke, the most common type of stroke, is going to show up as a normal CT scan of the brain, essentially because we're doing a CT scan in the immediate phase to look for hemorrhagic stroke only. And I'm sorry, Ray, I forgot the third question.
I think that's it.
Okay.
So the question is, as you talk through the stroke, and you got me missing where I was going to go with this too, because there's the many different types of strokes. One of the questions that comes up is the lacunar stroke. We have a question here from a person whose younger person was out inner tubing this last summer and had paralysis on one side of the body. Has to use a cane at the present time. And the question they have is, there a risk for another stroke in this person? And what is a lacoon or a lacunar stroke?
So lacoon is basically a type of stroke that generally is thought to be caused by small vessel disease. However, so it's thought that hypertension, diabetes, all these kinds of problems are the reason for it, as opposed to an embolic stroke, that comes from a different etiology. Basically, it could come from the heart. It's a clot that's traveled somewhere else. So that's mainly what the distinction is. And unfortunately, you can actually have embolic strokes that are very small and fit the classification radiologically, on those pictures that we get as a lacunar stroke. So you don't always know for sure. About actually 15% of lacunar strokes are actually probably embolic strokes. And the difference is important because the way that we treat these strokes is different. Again, it comes down to the stroke risk factors, and knowing the reason for the stroke is very important to try to prevent another one. So,
Change course just a little bit. Emily, vertigo, what is that?
Oh, that's
And
a great
how can you
question.
fix it?
Okay, that's a great question. I think besides an Alfred Hitchcock movie, right? Vertigo is a term that I generally, you can correct me on the precise definition, but it's sort of the symptom that the room is spinning around you. It's a sense, someone might describe it as dizziness, but it's a specific type of dizziness where you feel off balance. It's not so much that you're going to faint or pass out, but more that the room is spinning. I sort of tell patients that you just stepped off a wild carnival ride and your brain is or you're a kid that's spun around 15 times and then you stop. So it's unfortunately a very uncomfortable feeling, usually often accompanied by nausea or even vomiting. And the causes can vary. Most commonly, as a family physician, I tend to see the more benign or less worrisome type that is often an inner ear problem, a labyrinth or inner ear problem. But there can be more serious reasons for vertigo symptoms. Often the most common thing that I see is it will be sudden onset, no obvious cause. Sometimes it can be preceded by a viral illness, can be quite severe at first, and usually time limited, will go away on its own, and we support the person with sort of taking them off work, giving them some anti-nausea, anti-dizziness pills. But there are ways that your physician can sort out if you have the more serious kind, and certainly if you have vertigo that persists and doesn't go away, that's something that would necessitate more investigation. There are individuals that have bouts of vertigo, comes and goes, and we often will look at that as probably less worrisome in most cases, as long as it fits a similar pattern. And often, when you talk about cause, I alluded to the viral infection, but often there's a type that has to do with how the inner ear works and how our brain figures out where we are in space. And a disturbance in there will cause something called benign positional vertigo, where you will trigger your vertigo by a certain head movement. And certainly in my office, that's what I see the most, but that's not the only reason someone might have vertigo.
And if I'm as a stroke doctor, this is one of the things actually that we see missed as a stroke is vertigo. This is probably one of the most common missed strokes is the posterior circulation strokes, which cause vertigo. Several times a month, I end up with a patient that has been sent home from the emergency department with some sort of vertigo. Or nausea, diagnosed with benign positional vertigo, or gastroenteritis, or some sort of a vertigo-related diagnosis that ends up being stroke. These are really tough, strokes to diagnose. Patients will have virtually no symptoms, no signs on neurologic exam. And it's amazing the stroke that you can see correlating with your clinical exam, and you really have to have a high level of suspicion for this as a potential stroke.
So the question that I forgot, and I didn't ask you before, but the one that comes up, I believe the EMTs and paramedics and others have talked about what are the questions and what are the signs you look for if you're wondering if a person's had a stroke. And I don't remember them, so I'm not going to put them out. Did one of the three of you know those signs that if I come across you, it has to do with speech, it has to do with movement?
Right, the face, the arm, right. So basically it's the easiest strokes to diagnose are the ones that have unilateral changes. So you can have unilateral sensory changes.
So this is somebody at home watching.
Right.
Okay.
So, oh my goodness, my face is numb, my hand is numb, and my leg is numb. So if you have that sort of a presentation, you're going to want to get to the emergency department right away. Same with weakness. They have facial weakness. They're arm is weak, their leg is weak. Again, this unilateral weakness. Slurred speech is another one. But having that as the only possible presentation of stroke in our minds is dangerous, because again, we have these posterior circulation strokes that can be devastating and actually very dangerous, because of the way that the brain is set up. Posterior circulation strokes can cause compression that can actually be life-threatening. Also, visual changes are important not to miss. Invariably, once a month or so, I end up seeing a patient that's been diagnosed with migraine in the past and comes in with a visual complaint that might be kind of migrainous, and here, sure enough, actually this was a stroke. So again, it's sudden neurologic change.
Essentially, if something doesn't work.
Exactly, that's a good way to put it.
I mean,
yeah.
I don't like to pigeonhole facial weakness or speech problems. But people know themselves, and if something's not working,
Good way to
there's
put
going
it.
to be a reason for it. And we might not find out what the reason is. But at least in my phase of
Right.
medicine, I can tell you with some amount of assurance what it is not. And that's, in my opinion, one of the more important things. If something's not working, your vision, your speech, your function of your hand, your ability to walk in a straight line, then go to the emergency department so that we can try to figure out why and make sure that it's not that way because of a stroke or because of a seizure or because of a heart attack. That's why we're there.
Absolutely.
I just want to chime in maybe a little bit on headache, and I'd be curious what you have to say. Because a lot of patients ask, well, if you have a stroke, you don't have a headache, or you have a headache? And I think that's another one of those that I think it varies according to what's happening.
Absolutely.
But just the fact that you don't have a headache or do have a headache is not enough to make the decision.
Hemorrhagic strokes, you're more commonly experiencing a headache, and usually a pretty severe headache. But about a third of ischemic strokes actually have an associated headache.
Okay.
So,
Great.
Nick, this mom wants to know how to help her son be protected from getting concussions, her football playing son.
Well, sure. Well, the best protection would be to not play football. But that's not entirely reasonable. I played football when I was younger. The next best thing is going to be a secure use of a helmet that fits with mouthguard at every single opportunity where there might be contact. And then I guess the third most important thing is going to be that if there is head trauma or head injury, which results in any sort of symptom, and that can be anything from headache, mild to severe, fatigue, irritability, nausea, vision changes, and that's anything from loss of vision, a partial loss of vision, or double vision, or even strange color vision. All of these things are cause to essentially overreact. And if a person is active in contact sports and they have head injury with symptoms, well, they are to be immediately and completely inactive. And I think that's an idea which used to be an odd concept for people, but is gaining traction, in part because of some of the publicity associated with professional sports. If there is symptoms, I would encourage presentation either to family doc, primary doc, or emergency department. And what I counsel people is if there is concussive symptoms, that they are not only on a strict regimen of physical rest for a period of 24 to 48 hours after the symptoms abate, but also what we call cognitive rest, which means limited phone texting, internet use, that sort of thing. And unfortunately, sometimes the symptoms go away after an hour or two, and sometimes they last days, and sometimes they last weeks. And it's very difficult for neurologic professionals to predict how long certain conditions are going to last, and this being one of them.
Other comments?
Well, I certainly think you're right that with what's gone on with the National Football League and others, you know, prevention, I think it can be tough in the office too to make those predictions, and coaches and players want to get back to play as soon as possible. But as you so
It's one of those
artfully
circumstances
put.
where somebody has to look at the bigger picture.
yes, right.
I want to thank you. This has been a great tutorial on stroke tonight, and there are many questions that we did not get to. I want to thank our panelists, Dr. Nick Itzin, Dr. Emily Onello, Dr. Ruth Thomson, and our medical students, Ben Doomer, Susan Hoym, and Danielle Lavasser. Next week, join Dr. Ruth Westra for a program on cholesterol problems, when her panelists will be Dr. Krista Christian, Dr. Brian Horst, and Dr. Jake Powell. Thank you so much for watching, and have a good night.